So those are the aspects of personalized medicine that I think raise very significant social challenges, commercial challenges, legal challenges, and go way beyond a focus on just simply genomics.
That's wonderful. I like both of your thoughtful perspectives. I noticed both of you mentioned the word the clinic, going to the clinic, and the way that this type of information and this knowledge is pretty esoteric, and we're going to be interfacing with clinicians and traditional MDs. You know, Dr. Burke is both a PhD and MD, so she has her feet in both worlds. But for MDs that are currently, you know, at your average hospital, how do we move away from what I would say is sort of reactive medicine, where someone walks in and they have a cough and then you diagnose it from there, to something that's more proactive? And if you could just give your thoughtful perspective on that, Dr. Burke.
So let's start by saying that medicine will always necessarily be have a huge reactive component, no question.
Absolutely.
People fall down and break their legs, medicine has to respond. When we have effective therapies that work very well at the time that symptoms begin, we don't necessarily need to be proactive.
Yeah.
We need to apply that medicine. So again, I think we need to put things in perspective. The question, I believe the question you're posing is what I would call the vision that something like P4 medicine, or in general ideas about personalizing genomic information in terms in order to guide healthcare, sort of place before us. And that is the idea that as we know more about the particular realities, that data cloud around a particular individual, we will be able to arm that individual with the information to prevent disease. Preventing disease is a wonderful thing, and clearly we need to do that to the extent that we can. But a bit of a reality check here. We have huge opportunities for disease prevention that we are not pursuing in this country, and they fit very well under the one-size-fits-all, because it turns out a lot of preventive care is one-size-fits-all. Let me talk to you about smoking. Some people are more susceptible than others, both to the likelihood of becoming addicted from smoking and to response to and to the risks of disease once they smoke. No question genetics plays a role. But if you look at what we are accomplishing in this country, we've actually made extraordinary strides over the past 2 decades with pretty straightforward population-level public health interventions. That's why we're sitting in a room where nobody's smoking, and what a good thing that is. What a good thing it is. I can remember when you had to worry about whether you were going to be in the smoking section on the airplane. You know, we've come a long way. Now, if you look at that smoking issue, I think we can say 2 things. One of them is a small cheer for genomic medicine, and that is that there are people that have a really, really tough time quitting, and it looks as though genetics will be useful in guiding therapy for those individuals, a branch of medicine that we call pharmacogenetics, and that's a good thing. But if you look at the statistics on who smokes, rates of smoking are upwards of 30–40% amongst disadvantaged populations in this country. Homeless individuals, many minority groups have extremely high rates of smoking. The rate of smoking amongst doctors, 2%. Doctors don't smoke for the most part because they've had amazing education in just how bad smoking is. Now, the 2% who smoke might well benefit from pharmacogenetics to guide particular drug therapy to help them get away from smoking. Of course, the fact that there's no smoking anywhere near where they work anymore is probably also helpful. I would argue that in populations where people are smoking frequently, We need to look very carefully at why the public health interventions that have been so successful in many sectors of our society have not worked. There's a very interesting article in the public health literature that talks about colloquial epidemiology as a reason why many people continue to smoke in the face of well-publicized knowledge that smoking is not good for you. The way the argument goes is as follows. These are people that have a pretty good understanding of where they sit in the food chain in terms of health risks. And they've made a calculation that quitting smoking probably isn't going to lengthen their life because they are sitting in a situation, they're homeless perhaps, they're subject to a variety of environmental stressors and exposures that in fact predict that they will have a very shortened lifespan. We know that there are some segments of our society whose lifespan is comparable on average to that of people in Bangladesh. So why not smoke in those circumstances? Maybe that's a quite rational choice. And my point here being that I'm not saying there isn't a role for molecular personalized genetics or that data cloud, but I am saying that there are urgent healthcare problems that really aren't going to be addressed that way, and that a one-size-fits-all approach to preventive medicine probably is the most important opportunity to pursue around a variety of preventive issues right now.
So there's always going to be a role for a one-size-fits-all approach to public health issues, and clearly, smoking was a great success in that. But there is absolutely no reason in the world we should confine ourselves to that, and clearly that has had its limits. Study after study shows that there's a rising tide of type 2 diabetes and obesity, and complex diseases are really a problem in our society. About 75% of our healthcare costs go to managing, not treating, not curing, but just managing complex diseases. So clearly the one-size-fits-all approach, which will always be necessary to some degree, has its limits. And we really need to start exploring alternatives to that limit. And we haven't done that. And we have incredible resources that are untapped. And one of those resources is our population. When the medical system really was designed in the late 19th and early 20th century, most people were agricultural workers and factory workers. About 10% of the population at most went to college. There really was no way to engage people to process science information from science. They just didn't have the background. Today it's completely changed. We have a relatively highly educated population, and more than that, we have a population that has access to an incredible amount of information. And that is a resource. And we also have a population that's increasingly able to create new networks using digital communications. That's an incredible resource for solving problems, and we need to engage it. So just to put it a little more concrete, let me tell you about how what we envision as P4 medicine projects, and we're trying to, and the folks at Ohio State University and at Peace Health are really making plans to go forward with this. So you take a population, hopefully it would be about 10,000 people, and bring them into this community that we want to create, and bring them in by family, not individual persons, but by families, and maybe even require a minimum of 4 people. Network them digitally with basically what would be a Facebook for software to facilitate their interactions and give them fine control over who gets what information. Put the doctors and the nurses and all the people from the healthcare system on as nodes in that system. As they get a window into those networks, and they get the ability to monitor information that they care about. Are you taking your meds? When's your next appointment? That kind of thing. Don't try to change immediately what the doctors and nurses are doing. So within all these network people, you go to each family, each network, and that could be biological families and mixed families. But you want to take advantage of the power that working with biological families gives you in things like sequencing and things. But you also want to work with blended families. So you identify the person in each network, in each family, that takes the most responsibility for familial health. And study after study shows that those people are there. And you reach out to those people to give them information and help them do a better job at what it is they do within their families. And you provide them with coaches and you provide them with navigators to help them do that. And you set up a channel of communication. So it's not a one-day event where you download a bunch of information. You really set up a channel of communication that's constant and ongoing and hopefully cumulative. And you work with these people that way. You give them what actionable information can be derived from that data cloud. And you have the clinicians and the scientists working together to determine what's actionable. You consult with the people you're serving to determine what's actionable, because a lot of what's actionable is going to depend on cultural factors and what they're willing to do, what they're not willing to do. So it takes a real partnership to come up with actionable information. And you attack behavioral problems in that way. Now that's very different than the one-size-fits-all. The one-size-fits-all goes with a mass industrial society where you're just dealing with masses of people. You know, they all buy the same refrigerators, you know, you march them off to war in mass and all that. We have a different society. It's becoming personalized, not just in medicine, but, you know, in retail, in every aspect of commerce. Personalized medicine in some ways is just going to be doing what companies like Google and Amazon are doing in other areas. So clearly, there's always going to be a place for one-size-fits-all strategies. And I don't think those strategies have been fully exhausted. But we have to start looking at the personalized strategies for changing behavior and engaging with people. I mean, it just makes no sense not to go forward with that, since our whole society is going forward with that same experiment in commerce and in finance and in other areas. Why not do that in healthcare? I think it has a lot of promise.
Can I just ask a question about that model? Is there a control group that gets the navigators and the coaches but no molecular data?
No, we're not thinking about doing that. I mean, that's been discussed. Mm-hmm. But I think the feeling of both the doctors and the scientists involved is that trying to do this with control groups, with that kind of control, is just not feasible. We're dealing with an area that is inherently messy. And there's probably no way we can avoid that. To some extent, it drives the scientists a little crazy not to be able to do that, mm-hmm. and the clinicians as well. But it's just inherently messy.